Hi, everyone. Thank you for joining us for Town Hall number 5 today on Test to Stay. We're pleased to have an array of speakers for you today, and we will begin with American Academy of Pediatrics Vermont Chapter President Dr. Becca Bell and UVM Infectious Disease Doctor Dr. Ben Lee presenting on the science around Test to Stay. And then our school nurse colleague from Massachusetts, Karen Rufo, is here. She's the director of School Health Services at Lexington High School, and she's going to share her experiences on implementing Test to Stay. And then finally, we have Ted Fisher and Jill Briggs-Campbell from the Vermont Agency of Education team, and they're going to fill us in on the logistical pieces and the plan that was released last Friday. Just a reminder, please keep your microphones on mute so we can hear all the valuable information shared with us today. And please use the chat to put all your questions in the chat. We will be pausing after each set of speakers to answer questions on that topic. So without further ado, I'm going to turn it over to Dr. Becca Bell and Dr. Ben Lee. Thank you.
Hi, everyone, and thanks for having me. I hope my sound is okay and that the slide is the right slide that you're seeing. So I'm going to just speak for a few minutes, and I'm here with my colleague, Ben Lee, who's a pediatric infectious disease specialist at UVM Children's Hospital. I work here in the pediatric intensive care unit, and I'm the current president of the Vermont chapter of the American Academy of Pediatrics. And also, both Dr. Lee and I have kids, young kids who are too young to be vaccinated, who are in the school system as well. So we're heavily invested in this topic. So I first wanted to start with, okay, where are things now? And, you know, what's the difference between this year and last year? So differences. So we started off this year compared to last year with students full-time in person. This is something that we all have been, you know, wanting. Parents, pediatricians, educators, school nurses, we know that students do best when they're in person, full-time in school. However, we are now in a year and a half into this pandemic, and the healthcare workforce, education workforce is stretched thin. And we have students with increased mental health needs. So this increased during the pandemic. This was reaching a crisis state before the pandemic. It has gotten worse in, you know, in various metrics, what we're seeing in our pediatric offices, what we're seeing in our emergency departments, in our pediatric floors as well. And then on top of that, and I think it's always a good thing to remember, is that the baseline student health needs have not gone away. So we all have jobs for a reason, and that is because kids have a lot of both physical health needs and mental health needs, again, pre-pandemic. So kids are still, you know, in my world, they're still getting cancer, they're still, you know, they still have diabetes, they still are getting in accidents. None of that has changed, right? So that's all still there. And then on top of it, we have COVID. A new thing this fall, which is really complicating things, is that we also have other circulating respiratory viruses causing upper respiratory infections. So you all probably noticed that blessedly last year, we did not have a lot of these common seasonal respiratory viruses. So respiratory syncytial virus or RSV, we saw none of that. We had none of that in Vermont. We had no influenza. We had really hardly any para-influenza. I saw no metapneumovirus. I saw no adenovirus. I saw like a little bit of rhinovirus. Now we have RSV now. We never have that in the summer or the fall, never. And so so this is complicating things because these are symptoms that look like COVID. And these are things that actually make kids sick and land them in their pediatrician, in your offices, in your clinics, in our hospitals, and it's leading to a lot of missed school. My kids have picked up those non-COVID URIs and shared them with me. So I just know how complicated it is. And then on top of that, we have the Delta variant. So we're happy, Ben and I are happy to talk more about Delta, but the big thing is that we all know is that it's way more transmissible. We don't have good evidence that it causes more serious illness, but it causes more cases. And with those more cases, creates a whole cascade of issues. And so this is just some of the coverage in Vermont that we're seeing around what is happening in schools when we have a positive case, the contact tracing that has to happen. Then we have students quarantining at home, and then the cascade effect that we all know happens where parents then can't work. And this leads to sometimes in other cases, other schools shutting down, not even because they have a lot of COVID there, but because people are out and staff are out. So this is a huge snowballing problem. So we're going to talk a little bit about something called Test to Stay, which is being employed in a number of states and other localities. And the idea behind Test to Stay is that when an unvaccinated student is considered to be a close contact from a contact in the school setting, that instead of fully quarantining at home, they can attend school if they have a negative rapid antigen test. So that's sort of the basis behind that. And I'm going to talk a little bit about the evidence that we have that shows this is a safe alternative. So this is a study that was published in the Lancet recently, and based on a study that happened in the United Kingdom. This happened during a time where the Delta variant was predominant in the UK. So remember, they had Delta predominance before we did. So this was last spring, but they did have Delta there. And what they did in the study is they randomized 200 schools. And I always have to say, like, we hardly ever have randomized control trials in pediatrics. We certainly don't have a lot of randomized control trials in pediatric COVID mitigation. So it's kind of a blessing that we have this study. So they randomized entire schools to either approach close contacts in the traditional way, which is have the students quarantine at home, or have them come to school. If they're asymptomatic, they get a rapid antigen and they attend school for that day. And what they found was that doing that rapid antigen testing and having them go to school was not any worse than having them stay at home, meaning that there was no increased spread of COVID when they compared those two groups. Karen's going to talk a little bit more about the process, and I know that you've all looked at what Vermont AoE has sent out, and in terms of how this would sort of work. And what Vermont has laid out is very similar to the Massachusetts model. And they have this like nice picture flowchart. So that's why I included it here in this slide. So essentially, again, this is for someone who's unvaccinated. They're considered a close contact. They come to school, they have a rapid antigen test. If they're negative, they attend school. If they're positive, they have to go home. Otherwise, the other important pieces of this is that they are meant to quarantine when they're not in school. So when they're at home in the evenings and on the weekends, they should be acting like they're in quarantine. So the reason why we believe and why we think the evidence is showing that this is a safe alternative is that this is particular to an exposure that's happening in the school setting. So this is not for the student who has a parent who has COVID and they live with them at home and they're a close contact in that from that environment. This is only for students who've been deemed to be a close contact from a case in school, because we know in that setting, we're much less likely to transmit COVID than in other informal settings like the home or just outside of the school. We don't really know what's going on there, but that tends to be a higher risk area to transmit are the informal settings and not the school settings. So these are for in-school exposures only. If students are symptomatic, same as it ever was, they cannot come to school. They follow the protocol in terms of getting a PCR test, having their symptoms resolve or significantly improve before they return to school. And we, from AEP Vermont's perspective, we're recommending universal masking for now, really until something changes about the way our cases are going, and until younger children can get vaccinated. So we always have been recommending universal masking, but certainly those students in test to stay need to be wearing a mask during this time if that's not part of what the school is requiring anyway. So Massachusetts is doing something similar, which is why we've asked Karen to speak to us today. This is the data, the most recent data they have posted. So as of September 30th, and they've had more and more schools sort of onboarding. So they've done about over 9,000 tests. The vast majority are negative. So they've done 9,127 tests. Okay, sorry about that. So the positivity rate is 1.27% so far. They post these numbers weekly, which is sort of what we saw in the UK study. It was about 1.5, 1.6% that turned positive in either setting, either in you isolate at home, you quarantine at home, or you go to school. We have the same positivity rate. I'm also just going to put a note in here and share the Massachusetts data around surveillance testing, and that's something we might want to talk about today. I personally do not think that surveillance testing is something that's going to have a huge impact in the school setting. So their schools can do pooled surveillance testing. Their latest data show that 0.9% have turned positive. So these are, as a reminder, these are PCR tests. They're just done weekly for the students that have opted in. They do it weekly or every other week. And this is their positivity rate. So it's very low. I'll also just point out, because I think this is really important, that their average turnaround time is 14 hours, which is like very enviable. And to use the local parlance, that is wicked quick. And that's not a turnaround time that we're going to see in Vermont. And so thinking about the idea behind this is that you pick up totally asymptomatic cases, maybe before they become really infectious or more infectious, by using this PCR testing. It is a lot of work, in my opinion, for a small impact. And so I think from an epidemiologic standpoint, surveillance testing is not necessarily worth the work that would need to go into it. The other piece that some of the Massachusetts infectious disease docs have shared with me is just that because it's an opt-in and because many parents are not interested in consenting for surveillance testing. And so you're only testing those students whose families are interested in doing it. So it's not as though you're testing the entire student population. So we can talk more about that if folks are interested, but I certainly give permission for whatever that's worth. I don't know if that's worth anything. To not do surveillance testing. So here are the challenges we're going to talk about a little bit today, and something that we've identified. So I'll say that Dr. Lee and I have worked with some folks from the health department, from AoE, from AHS, around thinking through some of the challenges to this program. So I feel very confident that this program is very safe, that it's a very safe alternative, that it will really help students stay in school, which is what we all want, and that it will not contribute to increased spread of COVID in the school system. I feel really confident about the safety. However, the logistics are challenging and it is a lot of work. And so I think, we're going to spend probably most of the time talking about that piece, but I do want to reassure folks that this is a very safe alternative. So here's sort of the list of challenges we've been talking about. staffing, ensuring a supply of testing, CLIA waivers, thinking about depending on how many students need to be tested in the morning, it sort of can delay the morning. There's still a need to contact trace on some level, but we have an opportunity as we're sort of developing or thinking through this program about how we can sort of streamline and make easier the contact tracing process. And communication to families, which is a problem now with contact tracing. It's like taking up a ton of school nursing time. How we can smooth that out as well. And I think Jill and Ted are going to talk about the platform that will be used called Simple Report, which is different than what they use in Massachusetts, but has some nice features to help with that communication piece to families. So that's it for me. And I wanted to turn it over to Ben to see if there were questions in the chat that he wanted to answer.
Thanks, Becca. There have been a few questions that I've been trying to keep up with in the chat, but maybe just for everybody to be on the same page, we can just briefly review. So one of the questions from Allison was unvaccinated students participating in test to stay and then being allowed to do school sanctioned sports. So that has been one of the big questions about the program, and my response was, right now, given the data that we have about the risks of in-school transmission, we feel pretty comfortable saying that really what we're talking about is the risk to the school campus, and so the campus would sort of be the unit that we're talking about. In which case, as long as they're physically at the school location, then that potentially could be an allowable activity. What it would not allow would be for students to travel off campus to compete at another school or be mixing with other school groups. So that might mean a student may not be able to play in a game if they're been identified as a close contact, but are participating in test to stay. This only would apply, the next question from Katie. Out of order again. From Raina, should we increase mitigation strategies with close contacts? Because right now we don't distance. Really the most important part of the additional mitigation really is the masking. And so as long as masking remains in place, right now we're not considering needing to re-expand any of the other mitigation strategies that, for example, that we did last year. Katie had a question about symptomatic versus asymptomatic testing. She said, I guess I was hopeful we could use a rapid antigen test to keep mildly symptomatic kids in school. So test to stay only applies to asymptomatic children. The rationale being is that even if a child doesn't have COVID, if they have another respiratory illness, that's another illness that we don't want spreading through the school, because then that means that many more symptomatic children who themselves may need to be tested, et cetera. So there is a big ripple effect. So this is only for asymptomatic close contacts where the exposure occurred in the school setting. Megan had a question. Are we going to discourage surveillance testing to stop within schools based on your comments? And really what we're saying is we know everybody is stretched thin, and there's only a limited number of hours in the day. And right now, if one has to make a choice, I would argue, and I think Becca would argue, that test to stay is probably going to be more impactful than surveillance testing, because test to stay will allow kids to remain in school rather than miss school days. Surveillance testing, you're going to be potentially identifying a very, very small number of asymptomatically infected children. And the amount of work required to do that relative to the benefits gained is probably far lower than the amount of benefit to be gained relative to the work required to do test to stay. Let's see. So I think that was as far as I got, as far as answers that I was able to provide.
And I'm wondering, I'm going to jump in and I know you'll be able to explain this even better, but one of the questions is, so far we've been saying we're not accepting an antigen test as a way to test out of quarantine and come back to school. How is this different? So the difference with this setup is that what we're doing is testing daily. So antigen tests are very good at telling us whether someone is infectious right now. And so yes, the PCR test is more sensitive, but the antigen test will sort of is really good at saying, you know, this person is not infectious right now. So what we haven't, and it still stands, if someone is sick and they go home or they're exposed and they go home and they get an antigen test one time, that's just saying like, you're really not infectious right now. It's not saying that in 3 days, you know, you might not then become infectious with COVID. And so that's the difference. So this is a daily test saying you tested negative today. We feel really confident that you're not infectious today. And you can attend school today because that's really, you know, important. But it's not really predicting what's going to happen 2 days from now. So that's sort of the difference. And maybe Ben, you could explain that a little bit better because it's really like the daily, we are testing during the time that someone might become positive because we know they were a close contact. We know like the time frame where they might become positive. Every day we're checking to see if they're infectious. That's sort of the way it works.
Yeah, and I can comment, provide just a couple more comments on that. So it is true that antigen tests are less sensitive than PCR tests. The reason for that is the way an antigen test work is the antigen test is designed to pick up the proteins that are being made by the virus, and you need a certain amount of that protein there in the sample in order for the test to be able to pick it up. The reason that PCR tests are so much more sensitive is it's looking for the genetic material from the virus. It's looking for the viral RNA, and if you have if there is genetic material there, what PCR is designed to do, it's designed to perform a chemical reaction that will take a tiny amount of starting material and reproduce it, you know, billions of times. So you can start with a tiny amount of material and end up with a ton of material. And that's why PCR tests are more sensitive. It can pick up infections where there's just a tiny amount of virus versus antigen tests where you need a lot more virus. The drawbacks to PCR is that, at least right now, there really aren't very efficient ways that are widespread where you can get an immediate answer. A rapid antigen test, you get an answer in 15 minutes. A PCR test may take, at best, several hours to several days to get a turnaround time. And so you can't really use them to get a quick answer in the type of format that we're talking about. While we lose a bit of sensitivity with antigen tests, as Becca mentioned, the fact that you're doing repetitive daily testing makes it less likely that you will suffer a false negative. And furthermore, this is going to be used in the setting where we think we're already starting at a low likelihood of transmission. Because in the school setting, we have, for example, good masking and close observation. So for all those reasons, we think there is a strong argument to be made for saying why in this specific scenario that loss in sensitivity is worth the trade-off in terms of safety and sort of an impact in terms of what it will mean to the kids and families. So hopefully I've been able to answer that question.
So there is a question in the chat, Ben and Becca, that refer to the antigen tests. Thank you for clarifying why the antigen test works for test to stay, but not in the manner that we've been accepting test results prior to this. So one person is asking some questions about the availability of the antigen test. Are there unlimited number of antigen tests because if we're starting a 7-day surveillance, we want to make sure we can continue with that 7 days over that period of time.
Can I answer that one? That's my wheelhouse. So yes, excuse me. I work with our logistics team on state of Vermont. Our job and one of our major goals right now is securing the supply chain. So, excuse me one second. Not COVID, I promise. Yes, that is a really important piece, and there's no intention that we would roll out this program if we did not have a secure supply chain. And so part of that, for those of you who say did the Abbott training yesterday, who jumped in feet first, what you heard about is over-the-counter test kits, and then the CLIA waivered, I think what they refer to as the big boy kits, because they come in a pack of 40. So what we're looking at doing is we already have on hand a fairly large supply of the CLIA waivered, but it takes y'all some time to get through the CLIA process, and we're facilitating that as quickly as we can. So we're also looking at getting you over-the-counter kits so that for those of you who are ready to sort of hit the gas and get started here, we're going to be able to get you started and then shift you over to the CLIA waivered kits. For those of you who may need a bit more time to stand up a program like this, you'll probably go directly onto the CLIA waivered kits. And we are continuing to work with that supplier. In addition, understanding that this is COVID times and the supply chain is under pressure everywhere. We've built, the reason that we've gone with, say, Simple Report as a reporting system is that we're building in for the future that if we ever needed to shift to multiple antigen test kits to secure that supply, it all uses the same reporting system, because we do recognize 100% that the CIC and BINCS system has not been user-friendly. That's 80% of my job right now is troubleshooting that. So a Simple Report, for those of you who have started to engage with it, you'll find it's a much more user-friendly experience. And so we wanted that kind of experience and sort of easy to stand up. So in answer to the supply question, the answer is yes, we are securing that supply chain.
Great, thanks, Jill. So the next questions are, Ben and Becca, we have several folks who have asked, sent questions in early. How do we address the concerns of parents related to antigen testing and PCR testing, and looking for some consistent verbiage to use across the state?
Yeah, I think our colleague Ted here can help with communications on that as well. But I think communication to families is going to be very important. And I think Karen, who I want to make sure we get to too, will have some insight into that. I think generally, this is a very popular program for among families. And so generally, I think the issue that people find is more that parents want their students or their children to be involved in test to stay, even with close contact exposures outside of the school. So we're going to have to be very clear in communicating this is for an in-school exposure only. I think that's actually going to be the hardest thing. But I think that for the safety issue, it's super rare for us to have this randomized control trial. We got this data from Massachusetts, like we're seeing 1%, 2% of students actually turn positive. I mean, that is so low. So we're feeling really, really pretty good that we can look at the UK experience, look at the Massachusetts experience, and share that kind of safety data with parents. I think that generally what we're going to see are families wanting their students to try to get into school with symptoms, for instance, or try to get or try to be in test to stay when they have some other type of exposure. And I totally agree that communication to families is going to be really important. and patience because now they've heard about it. And it's going to take us a while to really get this going. And so I know that like families have heard about it now. And, you know, if their child is being asked to quarantine like today, they're asking for it. I know that's happening. So that's also a challenge that we need to get out in front of and really communicate to families like we don't have these programs up and running yet.
Thank you so much for presenting that piece. In the interest of time, we're going to move on to our next speaker, Karen.
So thanks everyone for having me be here today. I'm just trying to set up my screen to share. I just lost it. Okay. Are you guys seeing it? Oh.
Yes, we can see
Yes,
it.
you are. Okay. So I have to tell you, down here in Massachusetts, it's a beautiful fall-like day. I hope you guys are having just as great weather as we are down here. So I want to just give you a little background. I work in Lexington Public Schools. It's a suburb right outside of Boston. We didn't have that many cases, I don't feel, last year. 208, there's a breakdown. But already this year, you can see we've had 8 staff and 32 students. So 15 out of the 40 have been fully vaccinated. And then when we talk about the test and stay, we're using the BinaxNOW rapid antigen test. And for those people that have already said, gee, we wanted PCR tests, we held firm on, we wanted PCR molecular tests, we still do request for symptomatic students to come back with a PCR molecular test. So we did hold our ground there. This is just like Becca already said, it's a daily quick check to make sure that they're not infectious at that point in time. We are lucky in that we also do surveillance testing, which is a lot of work. I see some of the comments. It is a ton of work. But I also encourage parents for the students that are in test and stay that week, that this would be a good time, if never, to be in that pooled testing, as it's a second set of assurances. So we administer it from the first day of exposure. So when we say 7 days, it's really 7 school days because there's only 7 days in a week. So if they're day 6, their day 5, 4 would have been on a Friday, or it's a 3-day weekend, we still test them that day they came back. Again, it's just to make sure that we didn't miss anything. But sometimes you're not testing them for a full 7 days because you don't find out hardly ever the day of exposure that that's the day someone's positive. And on the weekends, we use an EMED test for kids that have school-sponsored extracurricular activities.
Karen, sorry to interrupt, but can you just press the present button up in the top right so that the slides are a little bigger for people to see?
Top right.
Where it says, there you go.
Yeah, how's that?
Thank you. Perfect.
Okay. So our Department of Elementary and Secondary Education has some exemptions. So again, this is meant for asymptomatic, fully close contact. People do not need to engage in the testing, and it's only for close contacts in the classroom. So that's a problem, right? Kids that are in outside activities, like your soccer or football, dance classes, religious classes, it is only for the classroom because you will exhaust your resources. So we have a magic school bus here in Massachusetts. People aren't considered a close contact on the school bus, but that is because our buses, it's a federal mandate, everyone needs to be masked, and our bus windows need to be down at least 2 inches. And then anyone who's been a close contact, who's had COVID within the last 90 days. So we started it this September. Our first round of testing started on September 20th. We've tested 45 students so far, 3 high school, 3 middle, 39 elementary. We performed 175 tests. So, you know, some kids are only getting 3 tests, some kids are only getting 2 tests, some kids are getting 4 or 5 tests. And we've yielded no positive BinaxNOW yet. I will tell you, I have a close colleague who has had a couple of positives, and even though you wait the 15 minutes to read them, they turn blue right away when they're positive. So Some of our lessons learned in that it's a learning curve for both nurses and students. So my nurses were very candid with me, and that, I said to them, what did you think? They were like, I'm not going to lie, Karen, I didn't sleep the night before. I was worried how this was all going to work out. And the same thing for the students, right? And these were mostly young students that we tested. And they would come in and they would all be apprehensive. But like by day 3, the kids were coming in and skipping right out. And, it's just a learning curve. And if you can engage the students, that's even better, right? You don't want them singing songs, but you can say, hey, can you help me count to 5, as you're swabbing. So organization is paramount. We made sure that the kits were labeled, or we had Post-it notes. So when you brought in Jimmy, you knew this Post-it note went with Jimmy's kit. We found it easy to have 2 people, one doing the scribing and the reagent, and the other one doing the actual swabbing. I heard you mention the CIC software, so we are putting the results in Crush the Curve. And I already mentioned that we encourage those students to participate in our weekly pooled hours. And so when we're looking at staffing, and this is something we're exploring in my district, and I say family hours, which 15, 20 years ago, those would have been known as mother's hours. So there's no reason why, other than you want to take the kid out of school if they're positive, but if the goal is to keep as many kids in school as possible and do this testing, and it's a staff shortage thing, it's a pandemic, right? Hey, listen, we're all going to do better on our next pandemic, which hopefully will not be in my lifetime. But this time we're learning as we go. And so we need to be a little creative. We need to think out of the box. So ideally you want the kids tested before they go in the school building. But if you can't, it's better to test them an hour into the day than to not test them at all, right? So we have to look at, what's best practice and what's reasonable practice, right? Everyone is thin. I'm impressed the number of people on this webinar this late in the day. I'm sure a lot of people would like to be other places. So thank you for being here. So like I said, from the nurse perspective, they were unsure at first. They needed time to adjust, but it's a really quick learning curve. The parent, I have a nurse who's a parent in another district, and they did do theirs before school, and they all joined in the cafeteria. So you knew right away who was positive. There wasn't a lot of privacy. So I think somewhere in between, there's probably a good model. We did ours in the clinic, and we had screens up in between each kid. So there was privacy. We let them go back while the tests were cooking for the 15 minutes and would just call them back. But we had no positives as of yet. And the nurse parent was saying that it is stressful waiting. She had to wait there as a parent for the test results to come. So that doesn't work when you have bused kids, but that's what her home district was doing. So, and I don't know if, Becca, when we were trying to brainstorm what could be some better ways to do this, and we were thinking regionalizing it so that it's quick, right? You're open, you have test centers. If you're short on staff, you have test centers open 6 to 9 in the morning. Parents go by, get screened, and then get a pass to go to school. Or this nurse of mine who's a parent, we were talking about, wouldn't it be nice if we could do this the night before, right? So parents could do childcare arrangements, right? Like, is there, you're giving up 12 hours of time that they could be infected, but again, you'd be doing it the night before for that day. So we have a high vaccine rate, probably not as high as yours. I hear that you guys lead the nation, but that has helped us keep the numbers that who need to be tested and stayed in that protocol in our high schools down significantly, and in our middle schools, which is probably why you saw my numbers that we only had 3 in the 2 middle schools and 3 in the high school, but 39 in the elementary. Questions? Or do you want to wait till the end of the webinar?
I think we can take questions for you. So do you want to do questions?
You'd think after 19 months, I wouldn't have to try to find my mic. What I'm seeing in the chat are mostly questions that are not specific to how it's working in Karen's experiences.
Are most of the questions in the chat for like Ted and Jill to answer?
Like, how's it going to work here in Vermont?
So I do have a question for Karen around, and someone asked me this earlier today. You just mentioned that in some districts the parents wait, but how does it work in other districts? Like, if they're bused there, what do you do with them?
No, so in our district, we don't have parents wait. They come to school. Remember, we have the magic school bus, right? So they can be on the school bus and they come in and we'll test them then. And sometimes in the beginning, when we thought we were short of staff, we just went school to school. So maybe school A was tested at 8:30 and school B wasn't tested till 9:45. So that's the way we handled it. And I will say, and you know, I think the people after me are going to talk about the CLIA waiver, but I will say when Massachusetts started this last year, it was difficult with that whole CLIA waiver thing, but they mainstreamed it. So we had one CLIA waiver for the whole state and cut down on the paperwork significantly, like trying to make it as easy as possible. So I see the question in the chat. We don't make them wait for results. When you think about this, they were already in the classroom before they came down for testing, or they were there yesterday. So if a kid tests positive, today's Thursday, they were already in the classroom yesterday. So you're already going to be doing that contact tracing, right? So, you know, the one thing I will tell you with the test and stay is we feel a degree of I don't want to say comfort, but of less urgent to, it's not like last year when we didn't have these tools and there was a positive case and it was like the building was on fire, you know, get the children out as quick as possible. And at this time, we still want to get them out, but we do have these tools that we can test the remaining children to make sure that they're safe to be at school, if that makes any sense.
And the question here is, why do we wait until the next day to test close contacts? Students stay at school being close contacts.
So if we find out early enough in the day, like if we have an hour left of school, we could test those close contacts. So I will tell you what we've done in our district, and it's not what is reflective of Massachusetts. So our parents had to consent to all three kinds of testing. So symptomatic testing, which is just a hornet's nest that we won't go down just yet. And then there's the test and stay, and then there's the pooled testing. So it wasn't a la carte. Parents had to consent to all three. So parents were nervous. Well, would you let us know? Well, of course, we're going to let you know in the test and stay, because we have to let you know your kid was identified as a close contact. If they were within that DESE exemption and they don't need to be a test and stay, we're still obligated to let you know your child was a close contact. They just don't have to be in the test and stay program. So we do let them know. So we lose a little time there calling, 10, 12 sets of parents, depending on the size of the class and who is truly identified as a close contact. So if we can get it in the same day, we do.
That's great. Thank you so much, Karen, for all of your expertise and sharing your experience with us. Super valuable.
Great. Thanks for having me.
And now I'll turn it over to Ted and Jill for more information about Vermont.
Sure thing. So I'll just make a few brief comments and then Ted will pick up from there. So one thing that I just want to say sort of from the beginning is that as you'll be able to see, I think Ted's going to be sharing things on the screen. Test to stay is envisioned as, I've really been thinking about this as a toolkit. So, surveillance testing was one toolkit that we had when we did not have, we envisioned when we did not have the Delta virus. You remember surveillance testing from last year. It was a very different context, right? So the toolkit has expanded rapidly in response to what is being experienced on the ground, and a recognition that the way that things are operating with the huge burden of contact tracing and the quarantining of hundreds of kids is just not sustainable for our education system. So that it was the impetus for why more, right? And so I think it is really important to continue to frame a toolkit. So we want to provide you with the tools, provide you with use case recommendations. I think recommendations is a really important word here. And then allow you to be able to pick the tools that you need to respond to your local circumstances, understanding that everybody has different circumstances. So tomorrow morning, we have a webinar. This communication went out earlier this week, but please get in touch with Ted and I if you don't have the link. We're doing an hour-and-a-half webinar where I'll be going over the whole toolkit. So right now we're just talking about test to stay, but it's really important to remember to frame it as, you know, there's been a lot of comments in the chat about, well, what about PCR testing? Yes, PCR testing continues to be really important, particularly because we do know that our local community test sites are impacted. I have personally experienced this as a parent recently, where I needed to get both of my kids tested, and it took days and days and days to get the results. So PCR testing, particularly on-demand PCR testing in the schools, and then the take-home test kits, which we have piloted and ran into many a problem, and we're trying to troubleshoot all of those before we send them out, will be another tool in your toolkit. So tomorrow, you're going to get like the whole big universe, but today sort of just talking about test to stay. And so I really do encourage folks to please go to the website that that Ted is sharing here. We do have a really in-depth, many-page document that's looking at those use case recommendations that I think would actually help to address a lot of the questions that I'm seeing in the chat. Do I use this for high school students? Test to stay might not be the best tool for high school students because of those contact tracing challenges. Elementary schools, it may be a stronger tool for you. You maybe need to look at more like PCR on-demand testing in a high school setting. So we've laid out, working with our EPI team, our partners at AHS, many hours of going back and forth, recommended use cases for each of the tools. But again, you have the flexibility to adapt these as need be and based on your own resource needs. So what I do want to just really quickly make a couple comments on here is, what is it that you need to do to get into the test to stay program here? And some of you are hitting the gas and going for it, and we're going to really be supporting you as you get through that onboarding process. And some of you are, I've heard from many superintendents this week that are saying, we're actually going to get our team together, plan our logistics, try and understand what our resources are, what our needs are, what does COVID look like in our communities. Some of you may not have had a positive case in weeks. Others of you are being inundated right now. And then at that point, you'll make your own decisions about like, what is your pace for bringing these tools on board. So if you are moving forward, and I think the simplest step that I would encourage you to do is to, go do the intent to participate and submit your CLIA waiver information. It doesn't trigger anything but the state handling your CLIA application for you. So we were not able to get one statewide CLIA waiver. Trust me, we tried. But we are going to handle all of the CLIA waiver application stuff for you. So we just need to get some data. And then my team is sending it up through the CLIA process. So there's very little lift for you there. And that will just sort of get you in there, get that process rolling so that when you are ready, or if you decide to move forward, you're already down that path. The other thing that you need to do is you need to get yourself into Simple Report. We have been talking to the Simple Report team. It's a free data tool. It was developed by CDC. I can tell you I've personally gone into it, and it is way more user-friendly than the Binks and CIC portal. So I don't think that you're going to find it to be as burdensome. And it also has some really nice logistical tools in there that you can utilize on testing days. So for example, if you've got 15 kids, you're doing 15 tests, you hit the timer trigger for each one as you put the swab in, and it will keep track of each kid when they hit 15 minutes. And that way you don't have to have, 15 egg timers. So it also has immediate results that will go to you, obviously, because you're there, VDH and the families. So that communication is instantaneous, which is very, very handy. So I think that you'll find Simple Report to be a much more user-friendly environment. And we're working with the Simple Report team to set up office hours as well, if you need that help. Our team is working on a universal response testing consent form. We did make the decision, and it was based actually on the Massachusetts experience, to split off surveillance testing from response testing. So when the response testing consent form comes out, families will consent for all 3 potential response testing modalities or tools: the Test to Stay program, on-demand PCR testing, and then take-home test kits. If they want to do surveillance testing, they will just do it through the CIC website. We'll have a link and they can go do that separately. If you're still doing surveillance testing, which is absolutely your choice. So we are going to be working on that. I'm 100% working on the consent form right now. So you'll have that available to you as soon as the lawyers are done with it, frankly. And then the last thing that you need to do to get through those initial steps to do the Test to Stay program is you need to attend an Abbott training webinar. And it's an hour. I went yesterday. It just shows you how to actually administer the test and some of the pitfalls to make sure you don't do it incorrectly. But I think it's really important here to note that these test kits, whether they come in a pack of 40 or the pack of 2 you get over the counter, are intended for any Joe Schmo off the street to use. So these are simple, user-friendly. If you've ever done a pregnancy test, they'll look familiar to you. Although I will say I misread my first pregnancy test twice. So I should not be allowed to do these. But you attend the Abbott webinar, check that box off, and then you will get in touch with my team using our AoE COVID testing email address, which is where we always recommend that you go if you have questions about school COVID testing. That's your best resource. You'll let us know that you've done those things. You're in Simple Report, you've submitted your intent to apply, and you've done your Abbott training. And then we're going to work with you on getting you, if you're not CLIA waivered yet, we're going to try and get you the over-counter test kits. And if you are CLIA waivered, then we will get you the big box of kits. So, we're going to try, when folks are ready to move forward, to move you forward as quickly as you need us to. And we have had a good response from a lot of districts that are, in pretty dire straits in terms of the number of kids that they've got in quarantine and the impact on families that are really eager to move forward. And then we understand that other districts are in a different place, and that's okay. We can accommodate both schedules. So that is all I'm going to say. You will hear a lot more from me tomorrow about the whole landscape and all of the details. But that is it for now, I think. And Ted, I'll let you jump in, and then if there's questions in the, I'm definitely feeling an FAQ coming on based on the number of questions in the chat, but we can try and knock any of those out as well.
Sorry, when I started presenting, I no longer know how to use Zoom, so hopefully folks can hear me. Just nod if you can. Okay, I see Soph smiling, great. Hi everyone, I'm Ted Fisher. My day job is Director of Communications and Legislative Affairs, but I've been leading our COVID response team since, well, more than 18 months now, and I'm proud to know many of you and have spoken with you on the phone. So I appreciate you being here, and thank you for your questions. I'm gonna go over some of the communications tools in a moment, and we will go over these again as well tomorrow. I was gonna make a couple of additional comments before we go there, but I just wanna say, I've had a couple of folks asking in the chat, and just so I don't forget, We will definitely record the webinar tomorrow, and I might ask Becca and the VSSNA leadership if they might be willing to take that recording from us and provide it to y'all. We have a series of hoops we have to jump through to get it on YouTube, and if we can transfer it over to you guys securely somehow, and have you put it someplace. If that's technically feasible, we can connect offline about that, but we'll definitely make sure it's recorded. And we're also willing to sit down with you or take a phone call or go over any of the resources for you at any time as well. I've seen some things in the chat. We've had outreach from folks about the logistical and staff concerns, and we absolutely recognize the amount of work and pressure that you're under. We also recognize that folks, so we're getting folks saying, we need time to go slow, we need more time to work on this. And we, if that's the situation that you're in your district, please absolutely do that. We are changing our messaging statewide and to parents and some of our public messaging to target audiences other than educators about how they really need to wait for their school to organize things and for their school to communicate how the program is going to work specifically there. We know some parents are already saying, well, why can't I test today and things like that. So we're making sure that that is very clear, and making sure folks are aware of that sort of at the state level. And we're providing you as much tool, I'll go over the communications toolkit in a moment, but we'll provide as much as that background information to you as we can. That said, we have a fair number of districts and some independent schools that are raring to go and are working, ready to go forward and asking us how quickly they can get it stood up and how quickly we can get antigen tests to them, which is great. Put some logistical pressure on us to make sure that we get things moving forward. But if you are in that position, please, I encourage you to please keep going. And I will just repeat what Jill said and plug that even if you are thinking that it's going to take some time to get the testing actually working in your district, please do fill out the CLIA waiver form and any of the other logistical things that you can do now, so that we just can sort of front load some of that work. So Jill already covered consent. I just want to again emphasize that this is going to look different in every school district. We have a great variety of different different structures and ways of staffing, and frankly, just the local environment might be very different for you. So you have that flexibility. That's why we're giving you 3 sets of tools to really address that. And I just want to plug, Jill said this already, but I want to plug it. Please reach out early and often with questions. I think you probably already have the COVID testing email, but I'll put it in the chat in a moment. I'm struggling to present and do the chat at the same time. So I'll put that in there. Please do write to us. And I just want to say something too, like this is also self-interested. We learn a lot from y'all about what you're looking at. So like even if it's a small question, please reach out to us, because we get that feedback and that information, and that allows us to help you problem solve your individual problem, but also know if we need to make tweaks to the program or know if we need to add things. So for example, today we're going to absolutely definitely put out an FAQ, hopefully not too late tomorrow on Friday after we get the feedback from tonight's call and also from the webinar tomorrow. So I'm going to just go through a couple of we had a lot of questions about parent communications, and Secretary French presented some of this information to superintendents earlier, and I made the same comment as I'm about to make there. If you're not seeing something that's going to be really helpful to you, just tell us. We can draft something for you. Any of those things that are things that would be easy to do, that are lists that other school nurses and other COVID coordinators and school districts might benefit from, let us know. We can work on it, and we'll also, of course, be doing it in partnership with the health department. So we'll make sure that the messaging is really strong from the public health perspective. So I'm just going to briefly go over we have a little flow chart here. This is more parent focused, and it goes over all of the test types. It's a little bit big, but I want folks to be able to see. This is the flow chart of sort of how the antigen test works. We call this guy symptomatic Sammy over here. And then an outline of the other 3 types of school PCR testing that we're going. And also we want to note that if families do opt out, that's absolutely their right. They go into the quarantine process as they normally would right now. It's an important thing to know. This is more of a flow chart built for built for your use. It just shows the different recommendations for where each testing modality would work. And this is not loading real well for me, so you're missing some of the who, what, where, whens there, but the link is there for your use. And, you know, to the example of like what other resources might be useful, I really appreciated the Massachusetts flow chart that Dr. Bell shared earlier, and we'll probably do something similar for y'all based on sort of what our testing options are in Vermont. So we're always trying to learn. We learned a lot from Massachusetts, the Mass Department of Education's information on this. I got asked about parent. I just want to show this page because all of the test resources that I've just been showing you are here on the resources for school staff. The at a glance flowchart is also on the resources for family staff. So just so that you're aware, you see both buttons right here, and then also a little review of each of the individual programs with their own web page. I'm not going to click on this document because it will just download a Word document to my computer. But this is an overview letter for parents and families that you can take, cut up, slap your letterhead on, do whatever you need to do, make it customizable for your district. If there are things there that you're missing that you would like, we can edit, we can create another version. Let us know if you need additional things. We'll be happy to help with that. I'll just also note, there's a couple of additional template letters here. And my sense is that as you guys ask for more, we'll add more. But for now, these are all school letters for potentially, like we're calling them the trigger letters. So if you have a case and you need to start doing test to stay, we've got some template messaging there, which we also, gratefully learned from our colleagues in Massachusetts about for creating a lot of this resources. Some other communication stuff in here as well, and we're going to update this as frequently as we need to and as frequently as we can to make sure more resources are there. I think I've covered everything that I wanted to cover. We're happy to field any questions that we've missed that folks are asking.
I've been tippy tapping as quickly as I can in the chat. But I think, Becca, you asked a really important general question, which is, is there an all or nothing requirement? If you want to do one, do you not get to do another? Or, do you have to do all of them? And there's no requirement. I think that's really, really important. In my mind, you want all your tools available, whether or not you're going to use them or not, right? So in my mind, if I'm a nurse or anyone in a school, I'd like to be able to walk into a closet and have like my bin of white label PCR test kits and shipping supplies, which will be provided by the state. I did see that in the chat. I'm working on logistics with that, ensuring you've got all of the right shipping and labels. I would like to have a stash of home test kits that I could send out pretty much as needed, whatever I felt was the best use case for those. Those are extremely flexible once I get them working properly. I've got one right here. I'm troubleshooting, and then if we're doing the antigen test to stay program, I would want that ready to go so that if I have a symptomatic kid that comes into the office, I can swab that kid. If they're a positive antigen test, they get sent home and it triggers test to stay, and you use all the template letters as needed. If it's a negative antigen test, but they're still symptomatic and we don't want people getting sick, I could also right there do that confirmatory PCR test because I've got my test kits right there. And so I can do that confirmatory PCR test kit, still send that symptomatic child home, and then everyone can proceed as normal. This is kind of what we've outlined in our recommendations. All kids proceed as normal until we get that PCR test kit result back. And so if we swab that kid right there, that's going to be a much faster process. As soon as we get that, if the PCR test kit is negative, no kids had to be quarantined, right? If the PCR test kit is positive, you start antigen testing the next day. So for me, I like the idea of having all of those available to me, but there is no requirement. We're not going to say, hey, you didn't do that one, you don't get to have this one. That's definitely not the intention.
I'm seeing a question from Shirley about contact tracing, and I meant to add this to my remarks, and I think I either skipped over it or just forgot. So we've received feedback from your leadership yesterday about contact tracing. We've gotten individual feedback from some of your numbers or from your superintendents, and it's absolutely something that's very much on our radar screen. Something Secretary French is really interested in, and we're having conversations. We will likely reissue the contact tracing memo again with additional changes. I don't know what those will be yet, and we're also having conversations with the health department about sort of what our, what the approach is and how we're supporting contact tracing. So, a little off of the specific test to stay topic, but we recognize that they are really linked together, and that there's more we can do to streamline things and simplify. So, I can't say more than watch this space, but we're hopeful that we'll have some more information to share next week.
Yeah, I just want to add to that when this doesn't decrease workload. I mean, I think that I just want to be really clear, like this is a really, it's a safe alternative. It's a way to have students in school. It's a way for families. And I noticed, and I totally empathize with this strain on the relationship between school nurses and families and communities, which is so challenging. And I think something like Test to Stay could help with that. But we really need to think through the workflow for this, because right now, as it is, what I'm hearing is it's not sustainable with the phone calls that you're making late at night. So what are ways, like really simple, like how this is an opportunity to think about whether or not you're doing Test to Stay is how can we communicate with families when their student is a close contact, with the consent already happening with something like Test to Stay and with simple reporting out the results and reporting it to VDH. Is that a way that piece isn't adding on? But I think this is an opportunity for all of you to let your leadership know, like, what are some of the real specifics around contact tracing that are really weighing you down in terms of the definition of contact tracing. Because I think not being a part of having to do this every day, but what I'm hearing from stories is sometimes some of the language around how we're defining close contact is vague, and it's creating a lot of close contacts. And so this is the opportunity, I think, to revisit some of that language. And it's going to require you all letting your leadership know, VDH, the health department taking a look at it, AoE taking a look at it, but I'm wondering, and I'm hopeful, because right now it's not sustainable the way things are. The contact tracing right now is totally unsustainable. So that's something that I'm very invested whether or not you're doing Test to Stay and trying to work through, because it's way, way too much work and it's creating this animosity that you're in the middle of. So we would really like to address this as well.
And Dr. Bell, if I can just add one comment to that, and Ted has also put this in the chat. So real world example of how you giving us some specific feedback around contact tracing led to immediate results is we heard from one district in a direct conversation, hey, our school population is highly, highly vaccinated. We're doing contact tracing for 20 hours and it yielded 2 kids that weren't vaccinated. What can we do about that? And we were able to immediately turn around to our team and say, what can we do about this? And that, led to an update within 48 hours, I think, to the contact tracing memo. So that kind of specific, here's the sticking point that we can't get around, here's the time suck, is really important. And then the last thing I'll just add is that Dr. Bell's right that this is not a labor saving device, right? Test to Stay is going to be resource intensive. But I think that one thing that I've really been thinking about is you all are putting in a tremendous amount of effort, contact tracing, and then having to quarantine kids, right? So it's a huge amount of effort that is yielding results that are creating very challenging relationships between you and families, that are ending up with a lot of kids in quarantine instead of kids in school. I have 2 young children, so I 100% understand the impact of this. What we are envisioning here is shifting the effort so that you are still, it's still a lot of work, and there's no softening that blow, but the result of that work is going to be so much more positive for you all in your relationships with your families, and also will result in more kids having their bottoms in seats, right? Which is, I think, where we all want to be, safely having kids in school instead of these really challenging decisions that you're being asked to make. So I think that is really important, and that is the intention of the work that is happening at the state level. And I want you all to know that, and we understand the pressure and the challenges that you are facing right now. And we thank you.
So to Becca's point about if there are things, and to Ted's request, if there are things that you as a school nurse think could help contact tracing become less burdensome, or if things that have been changed already have become more burdensome, please put that in the chat right now, because we're sharing this chat with Ted and Jill after the meeting today. And so if that would be a great way just to capture everyone's thoughts in one place for them to review later. So do you see any other questions in the chat we might have Ted or Jill answer at the moment?
I'm seeing lots of questions and comments about contact tracing. And I appreciate what you guys have said about trying to ease that burden, but the comments I'm seeing are similar to, it's not the notification of close contacts that is as time consuming. There are ways around that, but there's no way around needing to identify who the close contact is. So that piece continues. And of course, frustration with the lack of other people around to help out with things, and feeling that people are incredibly stressed, not just the nurses, but everybody.
Yeah, I really appreciate that. So if we are aware of that a lot of the contact tracing aspects are still there, which is why we're sort of going to the heart of the matter, and we actually need to update the contact tracing protocol itself. I don't have anything hard. Like we continue to have conversations about the staff level support. I don't have anything that I can concrete to share on that. I'm hopeful that will change. We exist in the same very challenging hiring environment. I've been asked a couple times, I'll just say this out loud for folks. I've been asked a couple times about like availability of National Guard or other resources. I'll just note that the National Guard, the guards persons that are available to support any state COVID response are all working on vaccination, and have been doing so since the vaccination program started, and they've been activated basically since the beginning. So unfortunately, we don't have more resources from them, and so we're very aware of that issue, and we're absolutely very sympathetic. I wish I had better news to share right now, but it's something that we're still working on.
So I'm just going to ask Jill and Ted, could you guys please clarify? Becca said in the beginning that this Test to Stay program and these tools are for an at-school exposure that has been contact traced and for those close contacts. I think there's some confusion about using the PCR test for other symptomatic students and other exposures. So could you please just clarify that for everyone very clearly?
Great. Yeah, so I think part of the challenge with this might just be that we started out really talking about Test to Stay, which is for the asymptomatic close contacts of of a positive case. And I did see this go by in the chat a moment ago. I don't remember who said it. I apologize. But if you have a student who, if you are set up already or in the process of getting set up through what's the surveillance testing process, you can do the on-site PCR testing, and you could give a symptomatic student a test, or you could send a symptomatic student home with a take-home PCR test that they could then put in UPS or return back to you for collection and shipping. And so yeah, we're providing those options, but they're separate from test to stay as an approach.
Hi, this is Ben. I was putting in a comment in the chat, but maybe I'll just jump in.
Sure.
So two things. Somebody mentioned something about vaccination. So it's a little bit of a different topic, but I just couldn't let that one go because it's a much happier topic. Like, it's going to be a game changer once, kids are able to start getting vaccinated. And so I just wanted to let folks know, at least in this state of Vermont pediatricians have had a tremendous response in ensuring that medical homes will be able to offer vaccine to kids when it rolls out. Right now, my current understanding is any of the pharmacies that are giving vaccine, they are able to do so for 3 and up. And then absolutely, I believe that there will be likely school-based clinics as well. So I think when vaccines for 5 to 11 come on board, there's going to be lots of different options for kids to receive vaccine because my suspicion is there's going to be a lot of demand very early on. The other comment I wanted to make was again about some of the frustrations with surveillance testing because that also continues to be a sort of a common theme. And a couple of comments is that it's not that surveillance testing doesn't work or doesn't have a role to play. But again, it's just trying to prioritize where are we going to have a better impact or more of an impact. I think from the experience of surveillance testing last year, I don't know the exact numbers off the top of my head, but the percent positivity rate, so the number of asymptomatic cases that were identified through surveillance testing relative to the number of tests that were done, I think it was well less than 1%. And so it's a lot of work to find a very few number of cases, whereas test to stay is, again, a lot of work, but makes a huge difference in terms of the number of learning hours that can be saved. So we're talking about number of days of school that have been saved for students. And so I think, again, with everybody stretched so thin, the question is, what's the better use of the resources? And I think that admittedly, this is a pivot. Plans for surveillance testing were set up, and sort of those conversations were started, even over the summer. It wasn't really until school started that the full impact of Delta, as it related to the school communities, really manifested itself, and that's really what's driving a lot of this pivot. So again, I just wanted, from my perspective, that's what I think the difference is between surveillance testing and test to stay. One is you're going to find a few additional positive cases, which would then trigger another round of contact tracing and quarantines, et cetera. The other could mean the difference between an entire classroom being able to stay and learn versus being out for 1 to 2 weeks.
Thanks, Ben. So next steps, I just want to reiterate to all the school nurses, your next steps in this are to communicate with your district leaders, to pick and choose from this menu what works best for your district, and to communicate with Ted and Jill any questions you may have to help you make that decision and to help move forward in implementing it. So to change gears totally, next week our town hall will be on condom availability legislation. And we've had that one set up for a while, so we are going to keep that in place. I know there's a lot of other things going on, but this is just as important in our job as all of these other topics. So please join us next week for Town Hall number 6 to hear more about the condom legislation. Ted, I see your hand. Do you have any last comments?
Yeah, I just, Dr. Lee reminded me, I wanted to say thank you, but also to just note on the happy thought of the EUA for the 5 to 11, the state is in the final stages of planning for that rollout. We are going to see probably very similar for those of you who hosted clinics at your school or your district was involved, probably very similar rollout where we'll be planning clinics in your area, going by district, trying to hit as many elementary schools as we can directly in the first few weeks after the EUA comes down, and then also working with the pediatric community and of course pharmacies will also have it available. So we're in the process of finalizing that now. We're planning to be ready to turn it on as soon as we hear from the feds, and we can provide some more information in the coming weeks about that to you all. So just wanted to make that note, because we're also happily awaiting that day with eager anticipation and planning to be ready to get as many shots out as possible, as quickly as possible.
Thank you.
And I just want to wrap by saying thank you all for your time, and we really appreciate the feedback and the questions, and it really helps us know what you guys need on the ground, and we'll solve every problem we can. So thank you all.
Thank you. And I'm sure we'll have another town hall when vaccinations come out. Just want to say quickly that the recording from last week never got posted. We are all volunteers on the board and we're just as busy as you. So apologies that it didn't get posted, but if anyone is interested in helping join our team for IT reasons to get these things posted, we would appreciate the help if you have that interest and would be willing to give a few hours of your time every week. So if you're interested, please email me. That would be great. Otherwise, the best way to get this information is to come to the live town halls at the moment, because we're all, like you, stretched thin for time. We're doing our best to advocate for you and do other things besides posting videos. Sorry. So I hope you all have a good week, and next week we'll be talking about the condom availability legislation. And thank you, Karen Rufo from Massachusetts, for coming today. We totally appreciate your special guest appearance. And as always, Becca Bell and Benjamin Lee, thank you for your scientific expertise that you bring to the table. And Jill and Ted, thanks for coming and teaching us more about what you guys have been working on. Have a great day.